So the concerns we have with our graduates. So this is something which we are seeing all over. There is something happening in these graduates. Of course, our previous generation also told us also the same thing. You all are useless. You all are not very good. So we are now having another similar issue, and no, I don't worry. Go from this. Right. Okay. So I thought we will first spend some time on why we need to introduce humanities. Now, this definition of humanities, medical humanities and health humanities, we shouldn't get too engrossed in that. Very simply, we have health sciences, all our health sciences, the physiology, anatomy, all that. Right? That's part of natural sciences, no? And we have things called humanities, which is about the human behavior and the human being. So anthropology, sociology, arts, philosophy, only humans can do it. You don't have animals talking about history, no? Right? So that is human activity. So there is this, we seem to be focusing a lot on the technical, scientific, biomedical aspect, not so much on the human aspects. So if you go to the humanities department, they are talking about literature and philosophy and history and so many different things about human beings. We are talking about the dysfunctions in the human being with a very biomedical focus. So I thought we will spend some time on this need to introduce humanities, because once we are convinced about that, you can use different pathways, and it's difficult to convince people on the importance of this with the curriculum overload, so many other priorities, exams, everything is happening, and now why do you want to bring in another subject? That's the way people will question you, and there are good reasons, including neurophysiological functional MRI. So we are on hard science when we try to explain why humanities is important. Second part, we'll discuss about how to introduce, and maybe that's something, once we are convinced, follow-up action would be that maybe, having further workshops or something where you develop what you all are doing. Right. So I'll start with a bit of a scenario that's a sort of Sri Lankan ward from Hiru News, actually, right? Okay, not uncommon, not uncommon, right? Why is that doctor behaving like this? The house officer. Why? Can you give one or two reasons? Yeah, work. Overloaded with work. Any other? Ego? Yes. Yeah, they might not have been trained to respond to these. In 30 seconds, under a lot of stress, you have to respond in a certain way. If you're not trained, you will shout. Right? So there are interesting things. One is you have things which are beyond your control, like the overloaded work, night duty, without any rest. He might have been struggling with 20 other dengue patients in the critical phase, and you are really exhausted. Okay, and the registrar might have blamed that house officer in the previous bed even. He might be already feeling humiliated. So many reasons like that, right? So things which we don't have much control, plus the person also. Now this is an area we are really haven't tackled in medical education. Basically, over the 5 years, we change a human being, and faculties, we are very powerful at doing that. We brainwash them to become different. Whether we like it or not, or good or bad, is not the question. We change them, and we all have gone through that. When we started, we were a certain type of human being. After 5 years, we became a different human being. You can always argue and say that this is what happens naturally. Yes, but sometimes the pathways are, seems to be a lot of influence of the system also on this change. So that's the other one, the human being, the ego, and lack of training maybe, and so on, right? Another example, a real story. The teacher was crying. I mean, she has taught generations of children who have, some of them have ended up as doctors. And this puny little fellow in the clinic is now trying to ask her, right, what's your level of education? You can imagine the pain the teacher was feeling. So, is this a bad egg, or is this something which is common? And interestingly, there are lots of research on this area, and for some reason the consensus is that round about the third year, when they start to go to clinical work, you see a decline in their empathy. They have looked at empathy. Now there are several terms. Empathy is where you get into another person's shoes and feel like that person. You feel like that person. Sympathy is when you meet a person who is begging near Sri Mahabodhi, where you give something and go. No engagement. You feel pity, give and you go. Empathy is different. Compassion is slightly more different, because there your motivation is to help. So that's like when a mother sees the child who has got injured, mother is not going to say, no, I'm also feeling, I must be poor child, she's having pain and so on. Mother's instinct is compassion, to alleviate that pain, and you're hardwired to do that. Okay, so there is this decline in empathy, and that they do with certain scales they have used, commonly used is the Jefferson scale, and you find this decline, right? So it's mainly about empathy that we talk about, right? Okay. What do you think is happening in Sri Lanka? Similar? Is there a decline? What do you think? Yeah, I mean, the general, certainly near exams, you would have seen, no, students going in towards no empathy at all, waking up patients. If a person has a murmur which is likely to come, that's a so-called good case, vinasai. If a man is admitted with a hernia or something during the exam period, finished. 10, 20 would be repeatedly examined. So those are all features of lack of empathy. You don't go and wake up your uncle or someone, no, negative, mata hernia ka balana, no, ne. You won't do it, no, to your own. Yes, you do, right? So, hypothetical, but this is probably the sort of thing which is happening. Thanks. Even with the postgraduate, there tends to be a further decline. Okay. Agreed with this to some extent? What are your experiences? You would have had your friends, some of who would have changed, you know. So some have survived. In fact, there are instances where some become very sensitive and they don't really decline. Some have declined and then realized and come up. Right. So I think a lot of us are in that category because with the exam, you don't realize that you are not empathic. You are so thinking about exams. Now, with overseas training, something else happens. Tunga empathy, you know, or empathic behavior. Might not be empathy from within the heart, but certainly you dare not show anything other than empathy. අඬනකොට ටක් ගාලා ටිෂු එකක් දෙනවා. Why? Because if you are not, you are sent back the next day. PG training is over, GMC registration is over, you come back the next day, or see also same, or New Zealand or whatever. Right. And now I might have shown this slide before. What happens after that is also very interesting.
It might increase because it starts the private practice.
Well, yeah, there is a. So you can have different pathways. Some are combinations where you are not empathic in one place but very empathic in another place. So there can be different. But there are some, you would have found there are certain people who are actually very bad in their communication and in the wards. I mean, you would have heard of horror stories a long time ago. I mean, they used to chase patients away if they are outside the visiting hours. I can remember when we were interns, the nurses, the sisters used to come and get us to chase. So යන්න කියන්න දෙන්න ඉන්න පුළුවන් 12ට doctor යන්න කියන්න. So we are podians, we don't know, we also go and say වෙලාව හරි දැන් යන්න. And the patient relatives might have come from 30 miles away, stood on a queue waiting to get into the hospital because they are checking no security. So by the time they come in also they are late, and then there are these little fellows in wearing ties who are coming and chasing them. So you can imagine the sort of environments we have all gone through. But you get people who have who are in fact the whole culture of wards. You will notice certain wards are very good. Patients like those wards. Certain wards, bad culture. The nurses, it can be related to a sister who is very strict, or it could be the boss. And there is a negative vibe coming from certain institutions. Those days, one such place was the labor room. Labor room, it was well known, where females used to shout at other females during when they have labor pain. So during labor pains, you have certain midwives and certain nurses who are notorious. And then doctors also get into it, into that same culture. And we used to hear of verbal anesthesia. That is, you scream at the person to stop shouting and trying to save the local anesthetic dose. Okay, so Those are horror stories, but those have really, really happened. So anyway, the issue is there can be different pathways, and hopefully this is something which we would like to see, and certainly that does happen because people become more sensitive to all this. They realize the mistakes they are making, and sometimes they do improve. So the take home message is there is a decline in empathy which seems to happen during the undergraduate years. When they go to hospitals, we have less control, but during the undergraduate years, we are having a problem. So I would like to ask you all, what sort of causes? Look back at your own medical student days. What were the reasons why you or one of your friends may have behaved in this manner? Any reasons you all can think of? Cicero?
Too long.
Too long ago, okay. Stress, yes. Stress, lack of support for stress, and not being able to cope with what's happening. Yeah. So if you are stressed to, take a good history, and the consultant is very strict, you don't care what empathy. You want to extract a good history, even if it is 10:30 in the night. No? Any other reasons? Any other reasons you can think of? Yeah. Yes, personality. Some people are hardwired in a way not to be empathic, and those are the bad eggs. And sometimes you can find them even during undergraduate days. In fact, that's the reason why the SLMC should actually be looking at student behavior also, because you find erratic bad behaviors in some who later have a very high chance of having problems with patients later on. Right? So there are several reasons of excess workload, the stress, mistreatment by senior colleagues. If you're being shouted at, if the senior registrars or registrars are strict with you, you tend to, you want to get rid of, want to do your work. It doesn't matter what the patient thinks because that fellow is shouting at you. Okay. And lack of support. Sometimes we are very distressed and there's no support. We don't have, we have counseling services, yes, in the universities, but we don't have debriefing, and counseling in these crises is a special situation. So that sort of thing is not there in the system, and certainly Ministry of Health, there's nothing. Ministry of Health, hardly any occupational health support for its own doctors. No, hardly any support. Right. So the systematic reviews have found. So these are some of the things, and you'll notice that most of these are outside direct control by certainly by the students, with some control by the university. And there isn't much which you can do with this environment.
So what is the empathic distress?
Yeah. So I want to get into that in a bit more detail. What is empathic distress? Now, empathic distress is one reason for people to react later on and have where they what shall I say, they have burnout and so on. The if you remember the internship, how many of you all have cried during the internship on the first few days when a patient died, cried or felt very sad? How would I? Yes, of course, I can remember the first death. Yeah, can you remember? Yes, right. Very sad with the first this thing. You are affected by it. We uh, felt with the patient's relatives. Now, do you cry when a patient dies? Nassauage Marino doesn't hit us, doesn't hit inside. So, what has happened is because of in that, when you feel, when you put yourself in another person's shoes and you start feeling like that person, there is distress. You can't survive if you are going on to have this distress every day. I mean, during our lives, we would have seen thousands of deaths. You ask an ordinary person, how many people have they seen dying? Looking at your face, how many? They would have seen zero. They wouldn't have seen. If at all, they might have seen a grandparent or a relative, and they would have seen sometime before death and gone off. That is not what we face. We face them face to face, dying. We face the relatives face to face when their relative is dying. Right? So the amount of distress we can manage is limited, and we start having barriers. So one barrier is where you develop a healthy distance. But some react. Now, a common reaction was when a patient dies and the relatives are crying, you avoid the relatives. What to pitipasem panada? We have done it. I have done it. Where you don't know how to cope with this. So you go from some other place, you go. Nurses have to handle the distressing situation. So you can react, you can respond in a bad way, just like what those doctors in those examples, or you can have a distance, and that's where the difficulty is. How distant should you be? No hard and fast rules, but how distant should you be? So empathic distress also is an important one, and that is within our capacity. That comes mainly with clinical practice more than certainly with the students, but students also face that. So again, this is another set of another systematic review, again, which reflects almost the same, right? Stressful workloads, lack of peer support, and prioritization of biomedical knowledge. And that's an important issue for us because we don't teach humanities or any subjects related to humanities from year 10. And now they have a basket of 3 baskets, I think, technical, humanities, and various things. From each basket, you have to select one at least. But the emphasis is less. Any questions up to this? So the important point is, are we convinced that there is a problem which we are facing? And part of the problem is that the medical students during their career are losing their empathy. There are causes which research has shown, which are some are outside our control, things related to the learning environment, role models, the stress of the exams and so on. But then there are certain areas which we may have some control in trying to develop this personality or the person. Right? Okay. Any questions?
So what about towards their colleagues?
Sorry?
Study towards their colleagues and their
Yeah, empathy during to their colleagues and self-compassion also. Some of these have been studied. Not much so much about empathy towards the colleagues, but self-compassion is something people have studied, and the loss of self-compassion is also noted. So there is, this area of looking at the human person in medical education is not there. We don't have much research. So we have behaviors, we have communication skills, we have professionalism, we have the technical skills, short case examination, and so on. But what really happens within that human being is not something which medical education has really looked at. So we are having a few things on, because attitudinal, attitudes and all these are similar, no? Now, all the time, the medical educationists will tell you that attitudinal assessment of attitudes is so difficult. We look at behaviors related to attitudes, but really, attitudes is something which is difficult. And what is happening is there is a change in the attitudes, change in empathy, change in that human personality, which is happening.
So one problem I see is that the selection procedure in here, because certain countries they adopt things like multiple mini interviews at the entrance, and then they kind of pick people who are at risk of becoming bad apples, and they leave. For example, in Australia, most of the universities, medical faculties, they conduct multiple mini interviews, and they have various. And what they say is that they can really correlate the marks students get in this multiple mini interviews to the feedback they get when they practice as doctors. So that's one way they, of course, it's not an option for us.
Yeah, I mean, one problem we have is we are getting people based only on the A level. Now, the issue is, what's the other method? You have, you say, teacher feedback, and then they start giving fridges and things to the teachers. You say interviews, give me 5 people. Give me 5 people who will not be biased in Sri Lanka, who doesn't know someone. No. And how many to interview? 20,000, 30,000. I mean, we can't do it. So we have compromised that by having a very strict exam. And unfortunately, the exam is based on content, or even in the interpreting, it has to be what the examiner wants. But at least it has allowed some sort of narrowing of inequalities. Because even the person who is far away now can look at the Rupavahini Taxila, DP education, and study and score. So that gap has narrowed. So we have compromised the selection process, but we have done very well in our narrowing the inequities because, you see, so that's the problem we face. So there are lots of people who, especially in the urban Colombo sort of areas, who say, why can't we have interviews? And because they haven't stepped into schools from outside Colombo, you see. They don't know the situation. They don't know that there are no teachers. Very easy to say.
We have a slight different view on this gap has been narrowed. I'm not sure about maybe in medicine and STEM subjects, but not in humanities and this thing because the quality of university education has deteriorated. So I'm not sure the gap has narrowed. The people who have means are not going to humanities in Sri Lanka. The humanities education and the arts and this thing, the postgraduate or the universities have collapsed throughout Sri Lanka. The STEM has survived, maybe law, maybe some, but maybe medicine and engineering, but I'm not sure. So the gap has actually increased in some way.
Yeah, I think the system has tried to narrow the gap by having this sort of, by relying on specific types of exams and mainly relying on, as a result, relying on MCQs and SCQs, which are regurgitation rather than application, and you're looking at knowledge rather than what the person was doing. So in that area, I think the system has tried to. What you tell about humanities is very important, and also there is I met Prof. Sarat Jayasinghe recently, and he was telling what has now happened is the baskets are there now, 3 or 4 baskets. So they are shifting now to the baskets which have the easiest way of getting a distinction. There is this craze over 9 distinctions now, O level. So you shift to a subject which will be least stressful. In the urban areas, people opting for Sinhala language and literature has gone down drastically. So which means with time to come, and rural areas they are still holding. With time to come, from a linguistic point of view, we are going to have a problem because we won't have that many Sinhala experts, Sinhala linguistics. So like that, I mean, you swing from one to the other, and suddenly you bring in certain things and you get unintended consequences. You don't expect. Same thing happened with English medium. You start English medium in schools, can't do it in all schools, only present in certain schools, can't give it to all the students in a school, therefore limited number. And who gets in to the English medium? In that area, it's not based on exam performance. This is anecdotal, but the impression is that it is the teacher's children and the affluent people in that village area who gets into that English medium because only 30 students also. So you bring in something, think it will have bigger value later on, but you are creating another set of problems which you didn't expect. Yeah. Any other questions or comments? So, okay. So, yeah.
So the other things that we don't really pay attention, as I personally feel, is that A-level students, when they select biology, and then aiming at the medical school, they basically have no understanding on what is the requirement for them to be a medical doctor in terms of their commitments and all that. The issue is most of the candidates are from we all are from lower middle class backgrounds, and then doing medicine is a good ladder to climb up in the higher levels in the society. So only that idea is there, but what is required, we don't have any understanding. So that we did a recently with an undergraduate student group a survey among all the medical students in the country. There are about like 2,000 respondents. Smaller percentage, about like 30% or something. So basically, large majority had no understanding what is expected from them in terms of commitment or what the society needs from them as doctors. So only thing that they knew was like this is if we pursue medicine, we will climb up higher in the ladder. That's it. So but then they become really hopeless or frustrated when they get into clinicals, then they understand, okay, this is our life this is going to be our life in the future. And then they start realizing more. So financially what would be in the future as well. Then you basically these are like uh, I think in one point our medical schools are like factories of making unhappy doctors. That's what we do. Unfortunately, we can't do anything because we have no way of
No control over that.
control over that.
Yeah.
But actually, that's it. So if you go for see what doctors post in their social media, doctors groups and all that, we have a whole generation of unhappy doctors.
Yeah, so I think
Sorry about that. I am reading this Inimage letter that has been encapsulated by Amarasekaran on his novels and this thing about the free education, and after 1956 Sinhalese education, people have climbed up the rural poor Buddhist. People have climbed up. However, it itself has posed a different class and inequalities, and yes, so beautifully shown in his books and novels. It's very
thank you. So I mean at the end of the day, we are limited by a whole host of factors on the selection process, which we don't have much control. I mean, at a policy level, we might have to work on those, but as staff, we are having to deal with all these negative things. And in addition, what we find is the curriculum also doesn't help the situation. It is making things worse. Even in the best of places, the curriculums are making them less empathic. And the anecdotal reports suggest that we are also doing the same. So now the question is, what can we do about it? Right. So in the next section, we will try to see how humanities can play a role. Now, when it comes to humanities, we are looking at thanks. Thank you. We will look at there are different, as I mentioned before, even some would include sociology and history and philosophy and so on also as humanities. So those are things which we have been asked to include. But there's growing interest in the use of the arts and humanities. How can the arts, like visual arts, literature, and so on, help in improving what we are doing in a medical curriculum? And for that, we have some neurophysiological basis. How many of you all heard of the mirror neurons? The story of mirror neurons is very interesting. They were having certain experiments where you had EEGs stuck on brains of monkeys, and they used to check the EEG with certain behaviors. And one behavior was where they give a plant and a banana to the monkey and the monkey eats. And now you are checking the EEG pattern in these monkeys. So like that they were doing on various other things also. And one day the technician came, EEG was stuck onto the monkey, but he was hungry and he ate the banana. And then they realized that the EEG pattern in the monkey who saw the banana being eaten was very similar to when he was eating the banana. So, in other words, even when you're not doing the action, if you watch the action, you seem to be mirroring that. That's why you call it a mirror neuron. I mean, there are controversies about this, but it's a very interesting way to understand this theory of mind. The fact that we can guess what the other person is thinking. And in fact, that might be one of the crucial things why we have evolved as human beings and become so successful. It's that ability to think, cooperate, be kind to each other, and as a species go forwards. And that's one theory they say, that why we beat Neanderthal. Neanderthal was supposed to be more intelligent, more physically able, but didn't have that teamwork, didn't have that interpersonal communication, the theory of mind, and so on. And there are people who have written about homo kindness, because they think that it's the human being's kindness which actually has, not the competition. This whole idea that competition and survival of the fittest does not apply in a species coming up. Okay, so the neurophysiological basis is there for empathy and so on. And with functional MRIs, you are now able to find out which parts of the brain are lighting up with empathy. What is interesting is that these are very similar to some of the areas which light up when you do a creative thing or in the arts. So there are lots of studies which have shown that exposure to arts improve empathy. In addition, we are finding neurophysiological basis also. And this, in fact, is a very interesting observation. This is what we were right now talking about. The fact that our students, when they come, are people who are doing only this. You would have heard of most, even sports, they stop. They stop everything after O levels. And the subjects they learn are also technical. So you are creating a group of people. We may be creating a group of people who are ready to be less empathic. Now, as Prof. Anjana mentioned, if you have that group saying, I am coming to do medicine because I want to climb the social ladder, You can imagine what would happen. It's like dynamite, right? So what we think we can do is this. We don't have much control from in this part before they start during A level. But once they come, whether we can use various techniques which will improve empathy or being kind towards patients. That's the basis of having health humanities, the basis of introducing humanities into health. Okay, now what's the sort of literature or data we have? I'll just show you two books. This is a very authoritative text which you can download from it's fairly recent, 22, 23, and gives a lot of basic data, neurophysiological data, clinical studies on the use of arts and humanities in medical education. So it's a good reference text. This is our own book. I have two copies. I can give that to you all, which also gives a more practical look at this, how we can use humanities in health professional education. Right, now we will try to go through a few methods so that you all will get an idea of what can be done. These are experiences from Colombo as well as other universities. We have just published a scoping review in the Humanities and Social Science Communication. That's a Springer Nature publication on the use of humanities in the region, and you find so many types of innovations which people are doing. So I've just picked up a few which we might be able to practice. Yeah, now narrative medicine, there are books on narrative medicine, and basically you're looking at patient narratives, their own story.
Your publications.
No, this is not the one. No, this is not the one. I haven't got a copy. I meant to have this thing, but it's just came out. It's open access. Yeah. Right. So now we did this. We do this in the faculty, where we send them to the wards early on. You can do that early on before they start clinicals or even during clinicals. But what is interesting is, moment they start clinicals, their brains have got pickled. You can't get them to speak to a patient without looking for a diagnosis. It's just like this Foucault's medical gaze in action. No, you have a nice human being who is able to speak to another human being and find out about the person's life. And within a few years, you've got that same human being who can't speak about anything else but about the disease that person has. Very interesting. We had third year students who were just starting their clinicals. So we thought we'll send them on this. At that time, we didn't know it was narrative medicine. We thought we will send them to the wards, this whole batch. So they come in groups. They have gone to different, and they come. We sent them 3 or 4 students to go and meet a patient. And the only task was write a story about this patient. Don't worry about diagnosis. Don't worry about examination and treatment and so on, from the time of birth until the time the person came to the hospital. Just tell us the story. So you'll understand some of them came. So if we start the program today and we have divided the group into 5, one group would come to medicine, 4 would have gone to other groups. So they spent 2 days with us. Now that first group, the virgin group who came to us, beautiful stories about their patients. After that, we are getting people who have gone to the other specialties now. They have already got brainwashed about history taking and diagnosis. They have already gone. Within a few days, whenever you send them to see a patient, they are bringing histories and examination and diagnosis and treatment. Now, why I am mentioning this story is that there is this, when you are speaking to a human being, when you are getting a narration, it's different from what we do, what we train. And that process itself is probably making them dehumanized. Okay. So narrative medicine tries to reverse that, tries to give another perspective to the student. This person who has got, who has come with a myocardial infarction is actually a human being who has had so many things and smoking cigarettes and can't stop smoking, who has tried to stop smoking and started doing this as a child and so on and so forth. They are katandari, right? And you use that to give that person centered. So you can do that. The other thing we do is use literature. Storytelling is, of course, in India they do quite a lot, but we focus mainly on literature. And an example, this is, you all know Henry Jayasinghe, right? So Henry Jayasinge's book, and the book is based on his experience because he got carcinoma.
His wife got carcinoma.
Also,
His wife got carcinoma. He looked after his wife, isn't it?
no, he had cancer. So he wrote this. Now read this. So the medical student's history will be, he was informed about the diagnosis and he was followed up at Maharagama Cancer Hospital and he had side effects due to chemotherapy. We have killed it. This is what he feels. So if you show this and get them to understand how breaking a serious bit of news affects a human being, how terrible it is sometimes when you go for continued medication like chemotherapy, and what suffering you have when you take chemotherapy. And the other problem we have is we tend to use English literature, but there is a lot of Sinhala literature as well as Tamil literature. And if you have Tamil speaking students, you can now, this is online, you can translate anything. It's no big deal now. So language should not be a barrier to what you want to do. And this is a A-level short story, Sahitya. of CKD. So when you, if that once they read that, and this, the idea is that once you go through, you discuss this story, and it's a story of how a sister who became a teacher because the brother sacrificed everything. When they lost their parents, the brother is the one who sacrificed and went to work at a very young age so that the sister could get educated and go to university and become a teacher. And when the brother, unmarried, living on his own, developed CKD, how the sister had such a dilemma, but she had finished her family without telling even her husband, became the donor, the kidney donor for the brother. So it's a very touching story. The idea is that once you read this, when the student meets another patient with CKD, at least in a few, it will strike a chord. Don't know whether something like this is going on in my patient. That's the idea. Okay. And I think we should try and use Sri Lankan literature. And he was one of our interns. He's a consultant anesthetist and has written about, again, about ICU, and I think it was ICU, and again, transplants are involved in this. But an interesting story for a discussion. In the international literature, you get quite a few which you can use. And there are websites which give you repositories of stories like this. But we must use our ones, because that's the one which will, the student will feel. If it is something happening in the West, student is not going to have that same feeling, because you have to have that, that innate sort of similarity. So now what we lack in Sri Lanka is where we don't have such a repository. We are trying to build one, Sinhala, Tamil literature, and even in English literature from Sri Lankan situations, right? Then another very simple thing, very powerful. We have patients, we have people who donate their bodies. So when they come to do the dissections, during our time, we used to be, I think we were never told to respect those bodies. It was horrible the way we used to crack jokes about these bodies and so on. But now people are more sensitive and we don't do that. But this is very powerful. You tell them, you write a letter thanking the relatives for giving this body for you to learn, what we call a silent teacher or a silent mentor. Very difficult to write, what to write, how to write, to whom to write, the language. And these are things which transform their way of looking at things. That's the important thing. This is transformative. Merely getting them to write a letter to the relatives of the cadaver. In certain universities, I've seen it in Singapore. Yeah, when you enter, there's a place where they have all these, they have got consent and all, but people who have donated, their pictures are there, and they are recognized as part of the faculty community, those relatives. See, I mean, if you look back even now, How many of you have really seen a body being handed over? I have seen that in Colombo because the mortuary door is in the car park. So when you go to the car park, you suddenly see this group of people who have come with their relatives' bodies. Usually it's not a Jayaratna or a Raymond, it's usually one of the small ones. And they are there. No one is greeting them or anything. They are standing there to hand over the body to the faculty. In some universities, you get students to go and meet them. Very powerful. Students to go and meet them and thank them. See, the moment you can imagine the happiness the relatives will have because future doctors have come and thanked them for giving my father's body to the university. So there are simple things which wouldn't take much faculty time, which we can do. Poetry. So we give a poem like this, and we ask them now. You comment. Now, currently there is an issue about AI being used. So when they have these, they have run it through AI, and then they give a brilliant critique. It doesn't go through their heart; it is going through the computer. So you have to have certain ways of doing it. You give it immediately at the time of the small group discussion. Finished. And they can't use their devices during the small group discussion. So this highlights, the fact that these are actually newspaper. These are newspaper. The helplessness of a couple because the wife is dying from chemotherapy. And the utter helplessness when a loved one is dying. So hopefully again, when they're doing the ward round and they see someone just holding the hand of a child who is very seriously ill, hopefully something will tickle in their brain and say, hey, I saw something like this in that poem of how painful it can be, because what can you do? I mean, there's nothing which you can do. It's all over. Curtain is going to come forever. Okay. This is from, I think it was picked up from Facebook by one of our senior lecturers. Yeah.
Monica Patel died of breast cancer. That's a whole anthology of poems.
Monica, yes, I've heard of that. Yeah. We have some of those books also which we get the students as reading material. Right. So it actually is, for us it is mastectomy. Thankfully, it's done less often now. And that's it. But for the woman who undergoes, it's a terrible situation. And you can complement with this. In Norway, they have a sculpture, public sculpture. recognizing the problem a woman would face when they undergo mastectomy. Surviving that is not easy, you see. I think some of the things which the medical profession we do to females is atrocious. Anything which is dysfunctional in the female, we remove. Uterus, any time, small excuse, uterus goes. You want to stop fertility, clip the fallopian tubes. Vasectomy? No. ඒක කරන්න. Women have been, your bodies are being massacred. Thankfully, it's less now because people are more careful and they respect the importance of these organs, you see, of the importance of these in womanhood, in their identity, which males who don't have such things don't feel like that. Okay, so we can use these examples. I'll give you another example. How we can use the visual arts. So we have talked about poetry, you can have sculpture. You know, suddenly you might find a student who can sculpture. We had during our medical congress, we got a person from the WAPA, the Visual and Performance Arts, to come and make a sculpture, do a sculpture. And you see, you develop these interests in the students also. That it is good to reflect, good to think about the human condition. Now, visual also can be powerful, and the issue here is it can be easily reproduced. Using visual, it is easy to reproduce and do. So the background to this is this painting, famous painting called The Doctor. So the person who did it, Phil Davis, he was actually recalling one of his sons who died and did this painting. Now, how do we use a painting for teaching purposes? We will do that right now. So, I'll give you about 30 seconds to 1 minute. What is going on in this painting? I'll give you exactly 1 minute. Okay, 1 minute up. In fact, they say you actually need about 15 to 30 minutes of staring into a picture to really understand what the artist was trying to say. So, what's going on? Sorry?
That's a sick child.
Sick child. Okay.
Doctor observes the child.
Doctor is observing the child.
And talk with the father.
Good. Father is in the background. Anything else? Sorry? Yeah, looks like as if the doctor is also thinking very hard. Mother seems to be not there. That is because you spent 1 minute.
Poor social circumstances given the background of the
Poor social circumstances given the background. And you mentioned that the doctor doesn't because the way he is looking at, no? Poor social circumstances because of that. So I'm giving the reasons also now. Right? Father is there, mother is also there, you can see, no? Yeah. Right? Okay. Anything else? Yeah. Sorry? Child is lying down on chairs, which means that they are so poor they don't have a bed. Right? Sorry? Maybe somewhere else, but more like the home also, no? Because all of them are there. Yeah. What more can you find? Right. Sorry? Darkness in the entire room lit by, yes. Yes. So there is, it's a quite dark one, and even the outside is dark. That's because this is during the Industrial Revolution. So it's polluted London. Okay. Right. Now, if you ask the question, what more can you find? One, we have already identified the doctor looking intently, the puzzle sort of doesn't know what's happening. Child looking at the child has dropped a piece of paper. That's probably from the hand. That's why the artist has put it there. Right? Eyes are closed. Actually, the child might have even died or in coma. The father is now, you see the father's expression also. Father is looking at the doctor. So, child might have died. Doctor is now puzzled. Is the child dead? Father is now looking at the doctor, very concerned, and consoling the wife with his hands here. And the mother is already praying. Mother knows it's finished. Right? And as you are quite rightly mentioned, shows the poverty of the situation, chairs, the dark area, the window, and the fact that all this is, shows that they are certainly from a very poor background. So this, what you've just done is what we call visual thinking strategy. What is going on in this picture? What do you see that makes you say that? What more can you find? Okay, so again, you're bringing in the human angle. You're bringing in a human angle, a humane angle. You can do this with photography. This is a photograph. It's there, the person who did it. It's from the web. And this was actually a man who was begging in the streets of India. Anything you want to mention? He looks a destitute young person, unkempt. We see this sort of people on the streets. Often they have a chronic, untreated mental illness, right? For months, can you see? And you can see all that. And you can see the concerned face that she has. Anything else? See, the photographer was not worried about Ramu. That's what he was. You can see a woman holding her nose. So after a few days of this photograph, Ramu died. But this is what was the painful part of this picture. So if you use these, you can give them powerful messages. Human angle of life. And now with mobile phones, the students can be very creative. They can take photographs. Of course, this sort of photograph you have to get consent and various things. But there are photographs which you can take with where you don't need consent to that extent. For example, dengue epidemic, comment you send them, take photographs of hazardous area. So they take the photographs and then they come back and you share it with the batch. And then the lecturer ties it up by saying, these are the common hazards we see. You all have missed this part. These are some areas which you all haven't photographed. Sometimes on the roof you get these water tanks you might not have seen. But that carries a powerful message. A learning, it's not necessarily your attitudes as such, but these are powerful learning tools also. So humanities, in addition to having its advantage of changing the human being and giving that person-centered angle, you can use it even for teaching. They've used this sort of thing for museums. Now, Rajarata origin first hospital documented in the world. Your students must be sent there because that's your identity. I mean, imagine you're having graduates who can proudly say, I came from the university and that's where the world's first hospital was started. I mean, that's a brand you can't beat. Colombo will turn around and say, we are having medical students in the oldest medical school, 1870. Make a centuries. Right? So, yeah, even museum visits. We haven't been able to do this, but people are using museum visits to bring out these. Even here, you all can use the museum and you all can select some of the exhibits they have to see and then create a discussion. Even if you start it as an elective, first year is probably important because that's the time you can, they become impressionable. We held an exhibition with the Colombo Medical Congress. We had a program on the masks, the Hartasanya, and it was actually organized by Santusha. This is Professor Lionel Bentarage, world-renowned specialist from, he was at Sri Pali before. There's a huge book also about masks. because Dahatasanya relates to certain illness syndromes, and we got people to draw. So this part was the Hatasanya, and then this one was what the interpretation by the artist. And then there was a group one. This was done by as a group. And these are the different people, from a bird's eye. Right. Can I have the clip? Yeah. So now you can use art, you can use poetry. The other powerful one is cinema. Yes. Watch this clip. This is Patch Adams.
Here we have a juvenile onset diabetic with poor circulation and diabetic neuropathy. As you can see, these are diabetic ulcers with lymphedema and evidence of gangrene. Questions?
Any osteomyelitis?
None apparent, although not definitive. Treatment to stabilize the blood sugar. Consider antibiotics, possibly amputation. What's her name? I was just wondering the patient's name.
Right, that's short clip. Just shows the importance of person-centered care. Now you show this to a second year or a third year, and your discussion could be on 10-minute discussion. See, instead of looking at the disease and the diagnosis, Patch Adams asked about the name and the difference it made to the patient. Right? So now here again, there are a whole lot of films which are available in some of the universities have, but we have to make our own ones. This is too Western sort of, you can get actors, you can get students will do it. If you all have links with the arts faculties where there's drama, they'll be most willing to help. So this is called trigger films. This was just 1.5 minutes. Powerful, just 1.5 minutes. But you can use longer ones. And you can, you can use this sort of film, right, to bring out person-centered care, ethical issues, communication problems, and so on. And we have what we call a med cinema. Prof. Tersi Chang is the one, a neurologist, he's the one who started this. Very interesting idea. Once a month, they have on a fixed last Wednesday, they have a film. They show a film. All the students are invited. This sort of location is fantastic. You have the film. And he brings out, of course, mainly medical sort of neurology type of ones, right? So there's a bit of preamble about the film. And then there's a critique, and a staff member can do that. So he selected these, you see. And Patch Adams was also shown. And there was one, for example, on artificial intelligence. Can't remember the name. The ethical issues which can come about by artificial intelligence, and this whole thing about transhuman and having a chip in your brain and so on. Then you can use performances. We haven't done this, but they do this in Thailand. You get a student, two students, one student becomes the carer, the other one becomes the patient. The patient sits on a wheelchair, and the other person takes the wheelchair and goes to a place like a mall. And you see the reactions of people. They are supposed to look at the reactions of people. How they ignore, how they talk to you, how they don't want to speak to you. And you can have other innovations, you can have a bandaged leg with some blood and various things. We also have combined these in what we call Humanities, the brainchild of Prof. Panduka Karunanayaka, where we use different inputs. So it needs some sort of expertise because we are having different inputs. Music, maybe drama, and music and things done by the students. They come and sing. They carefully select the songs. And after some time, you are getting volunteers. You have to push. You see, the current generations of students, you find some of them have gone to Visharada level. They are highly qualified and they are most willing to participate and participate in this. So music, dance also, real people dancing, poetry told by staff or one of the students, you show a film clip and so on. So this we try to link it to one of the learning theories called transformative learning, and we have tackled some interesting problems. One was about the LGBTQ, cancer. In Cancer and Us, as well as this, we got, of course, with consent, people to come and speak live. These were times when we had, some of these were Zoom, but we have live sessions now, much more than before. Even the cancer one, there was a mother who lost her child of leukemia who spoke. LGBTQ, we had a senior lecturer who was gay who came and spoke from the Faculty of Arts. And of course, even we tackle some of these other areas like Tagore's contributions and so on. Then when it comes to music, that's another fairly specialized area. But the neurophysiological basis is what's interesting because, see, when you listen to music, it's not just a passive auditory and the brain functions. Right? This is the normal resting brain or given sounds which are not music, and that's when you're listening to a good piece of music you like. So why I'm showing these is that the arts is as a tool in education is not only the studies, the trials which we have done, observational studies, there is a neurophysiological basis also. And few other things, we just held this history of medicine in Sri Lanka. He presented a poster, your dean presented a poster also here, right? So again, things which can interest students. Out of 150 students, maybe one or two will be interested. But that's the beginning. That's the beginning. Maybe one or two. That has been with any speciality. I mean, when they wanted to start research on snake bite and things long time ago, no one was doing research. In fact, rhabdomyolysis in Brussels viper was written Anuradhapura series by Edelston and Worrell and people, you see. No one in Sri Lanka was doing research on snake bite. Someone from overseas had to come and show that there's muscle necrosis. So even in biomedicine, at the beginning you won't have interest, but with time you will. And with the environment you all are in, you have a super environment for really bringing up history of medicine of ancient Sri Lanka to another level. No one can beat you all anywhere in the world. You are top of the pops in that because you have the best. The first hospital with the inscription. I don't know how many students have studied that Mihintale inscription on management of hospitals. It has been now decoded by Dr. Gamini Vijayasuriya and them. You can get them. They will love to come and speak. He gave a presentation in this also. Then we have lectures. This was he did on Chandima, who's retired now. He did on this is from the College of Physicians. He did on Da Vinci. He's crazy about Da Vinci and his art, and about the anatomy described by Da Vinci in the 14th or 13th century. Amazing, amazing. Then our own Prof. Somadeva, who's again series of lectures in NetFM has a whole series on history and on various topics. So you bring in these areas which are just outside biomedicine. Now we've got a lot of support for this. Again, it's important for you all to know because the WHO has just passed a resolution in 2025 and Sri Lanka was one of the key players in this. It was a Sri Lankan resolution, and we've been working on this from 2022, and it was for integration of health humanities, that some of the topics which we were discussing, into health professional education and training. So which means from 2027, there may be funds which will be available. And of course, all this is rooted through the Ministry of Health because WHO works with Ministry of Health. But there is certainly regional interest in this. And what's what's more important about this is the first such resolution in the whole WHO system. WHO system hasn't got a resolution on humanities yet. So you've got it through CRO, Southeast Asia region. Of course, the next step is to give it at the top level in headquarters. Yeah. We are coming out with a book. Release is 2026, and in fact, right now the final e-proofing is going on. It's a Springer publication on the arts and humanities in all these countries. So 3 of us are chief editors, one from India, from Nepal, other one from India, and myself. And it's a multi-author book, and hopefully it will add. You'll have some more examples which they are doing in different countries. So I'll stop there now, and I think we should have some questions. The rest, this is just for reference. You can have a look at it because you see, there are in implementing this humanities, there was a very important publication in academic medicine saying PRISM model and looking at the main sort of objectives which you can achieve with humanities. So mastering skills. Now, for example, that painting, mastering skills of observation could be one. In the doctor's one, right? In addition to developing empathy and so on, mastering visual observation. And there are studies which have shown that it helps. Perspective taking, that's your empathy and things. So the poetry, the short stories, Henry Jayasinghe, all that comes under this perspective take. It overlaps with personal insight and social advocacy, like the dengue photography. So this is I'm just highlighting this as to say when you are really trying to implement, there are various models which you can also use. Right, okay. Thank you very much. Open to questions. Yeah.
Thank you very much, sir. So, yeah. So basically, sir, we have started this exercise few years back. Now, the first outcome was anyway, we had a technical requirement to add some of the contents related to humanities, health humanities, into our curriculum because of the accreditation purposes. So we did that in 2017. But again, as I said that we have realized that we have not achieved our goal. And again, we had several discussions what to do and how to do this. And at the very recent discussion, actually, I should give the credit to Tutika. So he came up with the idea of we should go from the bottom up approach because we have prepared our graduate profile. We have identified 13 outcomes or 13 things in our graduate profile, 1, 3. So out of them, most except 1 or 2, all the other things can be linked to health humanities. So, however, without selecting a subject area, topics, and content, let's take the graduate profile and identify the problems we face. We know that we have all challenges that Prof. Sanjan and all highlighted. We don't have any control on our intake. We don't have control on our time frame because anyway we have to finish the program in between 4.5 years to 5 years time, and definitely intake from the A-levels results. So, however, whatever said and done, whatever the cohort we have, anyway we have to do something. So, we have identified certain problems as undergraduates that we have observed. From the undergraduates and from the doctors. So we have identified those things. So, and we have our ideal outcome as the graduate profile, and let's make a bridge or identify set of things how to address the gap. So that's, am I correct? I don't know. Yes, that was we discussed at the discussion level. Anyway, so now I have realized there are a few other things as well we can add. And anyway, in addition to that, we have discussed about the teaching learning methods as well that we have faced a lot of challenges. For the moment, it's mainly lecture based. Maybe it is one of the main reasons that we fail. Yes, we accept that. Again, we have to find out some of the methods which we can deliver with limited number of staff. Because we know that if we can have small group discussions, role plays, and different teaching methods are available, but again we need a lot of staff.
Absolutely. Yeah.
So we have to identify interesting and effective teaching methods that we can deliver with maybe a single teacher. So that is again another challenge, and we are working on that as well. So, however, we have just started. We have started few years back. We did lot of work. Actually, I did lot of work on that. But again, it was stagnating. Now we are restarted. We restarted the work to start from a different point. So we have to develop a curriculum. So again, it's from bottom-up approach. We are not, definitely we will go through the Kalam curriculum, what they are doing. Yes. But again, if we are developing a curriculum, our usual way is we identify subjects, areas, disciplines, and we identify the content. And yes, we prepare some set of objectives and all. However, here, so without doing these things, so we'll do it something practical. Maybe, I don't know what the medical education is saying. So anyway, however, so we'll try this way as well because we want to make an impact. Because even as teachers, we feel that this teaching is not effective. And at the same time, students are attending to lectures because we are counting the attendance and 80% attendance is mandatory. We know that. They are coming because of that. Not because that is interesting, not because that makes difference in their lives or in their professional character. So we have to do something different. So we have just initiated it. So definitely, sir, we will take you in and we will have a broad forum and we will proceed with that. So for the moment, I think that's enough from my side. So that is what we are planning to do. So yes, it's a difficult thing. And again, we should understand that so people do take this as a basket subject, especially students, because they are focusing about their uh, subject results, classes, distinctions, position in the merit list. Within all those things, somehow we have to make it interesting and we should get their full involvement in teaching learning process. So that's what we are expecting. Anyway, as you very correctly mentioned, if we can engage in this particular exercise, there will be more people in future. So that's what we are planning. So yes, it's open for the discussion. Any questions? Yes, sir.
Yeah. No, I think what you all are doing is absolutely super, because what I gave was a menu of things which you all can select from. So if you all identify the graduate profile, what are the areas which you think are important, which we can work on, then you will have the next stage would be where you try to see what are the sort of inputs we can give from the humanities to achieve those objectives. So you have a menu of, I've given some of the things which we have used or I have come across, but it's wide. It's wide. And as you quite rightly mentioned, you have to do something which will not stress the system. You can't have small group discussion. In Colombo also we are able to manage with difficulty. Because small group discussion, it is not only small group discussion during that batch, no. Immediately once you start having 5 batches will require small group discussions. So you will have those constraints. You will have to use things which are effective for the large group. So things like cinema, mini cinema, effective. Where you have sessions where students participate and you select, for example, you select certain topics and you get the students to choreograph it or have their presentations or songs or whatever and bring out a discussion, again large group. So like that you can innovate. So I think what you have done is the first step. That's the most important. What are the gaps you have and what are the things you have to tackle from a bottom-up approach, and you will have to prioritize. You won't be able to tackle everything. So even if you say we are going to consciously look at two aspects, and let's see how we can do that for a few years to see, and slowly take it forward.
So, do you use any assessment forms for these? Any, or is just all optional? Because that is the other question education is asked.
So, there are pros and cons. The moment you start having an assessment in this sort of instance where you want to change attitudes and behavior, what's the assessment we can do? Unless you are trying to use something like a 360-degree feedback or something like that. OSCEs are not going to help. SCQs are not going to help. MCQs are not going to help. Now, people criticize, saying, you all are doing the wrong assessments. You are doing the wrong assessment. It's like the A level. You are doing something wrong, but you are doing something which will at least bring in the importance of that subject. As an example, we'll say ethics, there are, or communication skills. Now, there are principles of communication skills which you can ask. You won't be able to examine the communication skills of 150 students. Clinicians will have to do that. They'll have to assess that. Ethics also, ethical behavior you can't, but at least you can ask principles of ethics. So like that, even in the humanities, if you're looking at the arts and other areas, bringing in those, very difficult to assess. So what we have is the Humanities program, for example. There it's compulsory. Admission, student presence is compulsory. And they have 6 or 8 during the 4th year.
So even the assessment of ethics and communication skills in postgraduate education is very imperfect. In Sri Lanka, we do it in English, and even in other developed countries, the problematic communication skills with minorities. So British, or even a Sri Lankan doctor communicating with a Bengali speaking Bengali white channel. How are they going to communicate? So they have translators and various other things. So the assessment of these issues, these are the problematic communities, not a Sri Lankan doctor communicating with a white 72-year-old white Caucasian man. But these are the communicating gaps that we need to assess. But they are being assessed very poorly, not even in ours are worse, but even in the MRCP, they are not perfect. They are bringing actors who are proficient in English and they are communicating English. So, but the large proportion of British population might not communicate freely in English also. If you go to USA, the Spanish is spoken by a lot of people. So like that, it's a thing that is not, those things cannot be assessed like humanities. How are you going to assess a novel? How are you going to give the best novel prize of the best novel? So these are very imperfect things. So I think it's best not to assess the undergraduate humanities stream or curriculum. I don't think we should assess it, but we can make student presentations and things like that. We can give a mark, or we can present, or we can at least give a mark, not a mark for comparing, but give a pass or fail thing like that for a student presentation or a student communication, group presentations, things like that. Like group presentation or a small drama or things like that. But that's a different, but not for a as you said ranking.
Yeah, I think you see now in this, it's important to look at it 2 points. One is we'll tackle the issue about humanities. Now, it's not a case of assessing the humanities part, because we are doing humanities to achieve certain things like empathy and so on, which are difficult to assess. One option is not to touch assessments at the beginning. Just leave it aside. Just leave it aside. In fact, at the beginning, behavioral sciences, we didn't have any assessment. Then we came to a system where you had pass or fail sort of thing, basic one. But then people get worried and they want to then start having marks and various things. So, but you go back now to Humanities program, no assessment, only a feedback. And see, with time they start coming because it's interesting. And there are certain topics like heartbreak. They want it because these youngsters are undergoing these crises in their emotional lives. And we brought, again, the arts were used in that whole process. You can't assess those. Anyway, you can't assess those. So I think just leave those aside, the assessment part. Second thing is, when it comes to communication skills and so on, because we are bound by certain structures, we are unable to have the optimum communication skills. Good example is PG. PG communication skills is done in English, right? Absurd. And we are making MD graduates for Sri Lanka and getting them to pass exams on communication skills in English. So we shouldn't, the way out, not way out, but another thing which we did was you bring in observe history taking and communication skills as formative in your training. This you have control. So if you want to test communication skills of graduates in Sinhala and Tamil, field is there because you have in your appointment you can do it. So you'll have to innovate like that. And I think this is all it's like a aspiration. You're going towards nirvana balagana now. As you go along, you try to improve and do things, and you get your feedback. Once you start, you realize how you can improve in that context. You learn as you go along. Yeah.
Yes, sir. I think you answered that in the last section. Now, when we introduce something without assessments, now, how do we know whether we are going on the right track and whether something that we introduce is working or not? Is it through the feedbacks or is there some other things?
When you assess, do you know we are going on a
Yeah,
right track?
Fine.
When you assess, if you are assessing, are we sure that we are going on the right track? No.
Yeah.
No,
I'm
sir.
not sure.
That's the thing. Yeah.
No, I think you see in some of these, you try to do your best, and after that, it's autopilot, right? Because you can't really find out. So sometimes you get positive feedback, intangible feedback. More and more students are coming voluntarily. More and more faculty members are coming to participate in those programs. Now that med cinema, which this one does in the evenings, totally no compulsory at all. Place is full. No assessment whatsoever. Nothing to do with the curriculum, right?
The obsession we have with assessments comes to the natural science.
Yes.
Definitions.
Yeah, absolutely.
So you see,
And also, we are not. You see, some of these things it's phenomenological. What is happening inside your mind, we don't assess that. We are looking at the outward behaviors. So what you say is true. We will never know. Much better not to sweat at this stage about assessments. Now in this place they did a very interesting experiment in Nepal. They had a program called Sparshanam. And in Nepal, they had a program called Sparshanam, small module for first or third years or something. It was a voluntary program where you ran certain one module with literature and various things. What they did was 11 years later, they found the people in that area, some quite a number were still in Nepal, and got them to write what their experiences were about Sparshanam program. And then you do a content analysis. You get some very interesting things, you see. How some of those inputs had really helped them to, in their, what they feel. What they feel is that it has helped them in certain aspects of communication or carrying of patients. So, again, assessments of attitudinal changes and the impact of these is at its infancy. We don't have tools, but until we get tools, we do the best and see. So quite rightly, I think, leave aside the assessment, make it compulsory. Now, one problem we are having is we make it compulsory, and fellows are signing false, Horat Sanghana. And they were having a session on that. You see, it's a culture, no? If you go back to our batches in Bloemfontein, in the boys' hostel, there were people who had seals of all the consultants to sign off any appointment. So that is part of the cult, this fraudulent signatures. We don't take it seriously. But we brought up this issue. How serious that signature is was when this case came up about Mr. Kehelia Ramukwalla's. All those who went in had signed, put the signature. It was the signature which got them into prison. Signature. Because we, in this medical student culture, we think this signature is not so important. Legally, fellows are very, very particular. Legal field, they won't. They're very particular. No? Blank එකකවත් අත්සන් කරලා දෙන්නේ නැහැ. Sometimes now, you go to sometimes these hospitals, they tell you, sir, අත්සන් කරලා තියන්න. I never do it. But they say, sir, අත්සන් කරලා සීල් එක ගහලා දෙන්න අපි ලියන්නම් බෙහෙත් එක. They want to help you. I say, no, thank you. If I sign, I have to write. Because you're worried what will be written. But that's the culture. Legal field, they won't do it. They will always say, don't sign anything. Never on a blank. So these are cultural things, and you have to, but the major problem is falsification. How do you all manage that? You all count. They have a register and they count. So then what happens is they find that the head count is less than the list count, and then big ha-ho. Yeah.
So just to add one thing, as we discussed about assessments anyway, we went through several stages because initially our assessments were basically the written type assessments, and we got, as you said, a lot of comments from the viewers about our assessment system. So now actually we have changed it to student-centered kind of presentations. So they are finding their own solutions to their own problems. So that's what we are doing in the assessments. Anyway, when it comes to medical education and the requirements and everything, if you are including anything in the curriculum, there should be some sort of assessment. So we are, for the moment, we are happy about the present assessment system, but we have to change the approach and the content.
Yeah, so it's always this compromise, what is required and what we can do and what is ideal. We'll have to. Yeah.
Sir, one thing I think that we can actually do is we have things like problem-based learning, case-based learning, tutorials. Of course, we can conduct them from the first years onwards. So when one experience we had when I was teaching in Monash for about 3 years doing problem-based learning. From the first years, themselves they participate in these PBL classes. So you give clinical as usual, you give pieces of information, but in each piece of information, they have to analyze the information, biological, psychological, social model. So it's not only the biology that we are interested in, they are forced to analyze or bring up issues related to psychological and social. So that actually triggers from the first year onwards. I mean, then it's very easy to, introduce this kind of things. In our city, what we lack is that basically. All our tutorials, even small, this case-based learning and things are heavily focused on the disease. So if we can actually include bit of these other elements as well, and to show the student that these are also important, then probably it might place the student in a better place.
Yeah, certainly, because I mean they use this biopsychosocial Elstein's model of handling scenarios, and see because it's an Australian private university, they are able to have this nice system. Because I know quite about the Monash system, because my daughter was doing at Monash, Malaysia. So they have actually, you have those cases which go throughout the 5 years. Now the problem with the issues we have is, the moment you do that, you can't get staff to do that. You see, you need a lot of staff. So how are you going to have this? And moment you have something which is going longitudinal, that means very soon, 5 years, you are having five things are happening. So those are compromises you have to make. Compromises you have to make. Yeah. Any other questions? So I think the important point is to start from the basics and to get on to identify what sort of areas, the gaps, select a few gaps, and then we can work on how to, the options you all have. Large groups වලට සමහර ඒවා පුළුවන් නේ. සමහර ඒවා පුළුවන්. Okay, right.